talk about neurohumoral modification in heart failure. And for many years, I used to think, now that we have ACE inhibitors, beta blockers, ARBs, and spironolactone, you can completely inhibit the neurohormonal system, and we had maxed out on this. And when neprilysin inhibition first came out, I'm not a late adopter. It took me a while to embrace the medication. We're a group of 11 heart failure cardiologists. We just do heart failure and transplant. And at least almost all my colleagues had used neprilysin in ARNIs. And I was a bit late to sort of adopt this medication. And as many of you all know, this medication has been a game changer, and it saves lives. And on hindsight, I think I was being overcautious. Part of it was my skepticism because the way the study was designed. Anyway, some of the talk is from this source. This is a book which I edit. There are over 240 contributors from elite institutions in the U.S. and some of the slides are from on this talk. I also want to talk to you about two resources here. One is a white paper, management of systolic heart failure in LMIC countries, which I co-wrote with Bill Deck, who's the chief of cardiology at MGH, and Jagat Narula, who's the dean at Mount Sinai. We also put together a STEMI white paper in LMIC countries from faculty from Africa and here in India. So if anyone wants a copy of these white papers, please contact me and we'll make sure I can email it to you. So to talk more specifically about management of heart failure, just wanted to put it in context. I remember when ACE inhibitors first came out in the SAVE study, we were very happy that the EF improved from 20 to 30%, and that was victory at that time, way back in 1990. And if you look back, ACE inhibitors actually, the relative risk reduction is only about less than 20%. It's 5 to 18% in the risk of cardiovascular deaths and chronic heart failure. So there was room for improvement. And the other contextual thing I want to put here, bring to your attention is the management of heart failure is most of the deaths in NYHA class 2 and class 3 heart failure is due to sudden death. And in class 4 heart failure, it's all pump failure, and sudden death is only a third. So as I give my talk, you'll realize, we look at all these medications as afterload reduction. We look at it very hemodynamically, but also we need to look at it from a perspective of sudden death and antiarrhythmic potential. So neprilysin inhibition involves both the natriuretic peptide system and the renin-angiotensin system. We already know about the renin-angiotensin-aldosterone pathway, so I'm not going to talk about it. Valsartan is the component for that. And the only big takeaway from neprilysin inhibition is BNP accumulates, and I don't know how many of you use BNP to monitor. In our hospital, we only have BNP, but now that so many patients are on neprilysin inhibition, it's a useless assay. I had a patient, I just got off service. He was walking and he was working as a janitor in the hospital, but his BNP was 1800. I said, that doesn't make sense. And the pharmacist actually rounds with us in the hospital when we are rounding. He said, Dr. Baliga, the sacubitril valsartan was started a month ago. That's when it peaks, the BNP, when you use BNP. So this could all be due to starting this therapy a month ago. So I think when I go back, one of the things we'll be pushing for is to use NT-proBNP. And if those of you who don't have this BNP in the hospital, I would recommend that you go straight to NT-proBNP because so much of neprilysin inhibition has become mainstream. And so going straight to so initially the first two trials were the Paramount study with Scott Solomon, who I know from the Brigham, did the initial study with neprilysin inhibition, small sample size of 300 patients. But the bigger game changer was paradigm heart failure, which John McMurray from Scotland showed the survival benefit. And so I'm going to go straight to the paradigm heart failure trial. And so who did they include? They included people with EF of less than 40%, which they later amended to 35% 1 year after the study was started. BNP above 150 or NT-proBNP above 600 if they're not decompensated. But if they were decompensated in the last 12 months, they used a BNP of 100 and an NT-proBNP of greater than 400. They're stable on ACE and ARB, beta blocker for at least 4 weeks, and they optimize the dose of spironolactone. The exclusion criteria is important. Angioedema is a big deal, especially in our African American patients. Kidney function, eGFR less than 30. So that's roughly a creatinine of around 1.8, 2. Serum potassium greater than 5. Low blood pressure, and acutely decompensated heart failure. So it's interesting, in this study, they actually set this patients to succeed. And what they really did, they first had this single blind run-in period of where there was at least 20% attrition. So they made sure that the patient tolerated enalapril before they switched to ARNI. And so for the patients for the first 2 weeks they tolerated enalapril, then they switched to ARNI, 100 milligrams twice a day, and then at the end of 2 weeks they doubled the dose. It was a one-on-one randomization, and the median follow-up was 27 months. And they compared this combination with enalapril, 10 milligrams twice a day, and something to keep in mind because there was some criticism about the control group. So what were the predictors of non-completion? Who are the people who didn't tolerate the drug? People with the low eGFR, so when the kidney function was low, high NT-proBNP, low systolic blood pressure, so when the blood pressure is soft, and ischemic cause of heart failure. So this just tells you the ones who would probably succeed, the patient who would succeed with an ARMI, and we discussed this yesterday, is the people with non-ischemic cardiomyopathy secondary to hypertension will probably get the biggest bang for their buck with this therapy. And when you looked at the baseline characteristics, it's interesting, the age was around 60 years in both the control group and the active group. 1 in 5 were women, and about half were ischemic cardiomyopathy. And the average EF was around 30%, okay, plus or minus 5. And most were NYHA class 2 and class 3. And remember, in my second slide, I showed that pie diagram. NYHA class 2 and class 3, most of the people died due to sudden death. And if you agree the received wisdom, sudden death is due to antiarrhythmic effect. It's not all hemodynamic. There's a big antiarrhythmic component to it. And if you look at the patient's heart rate in this study, the heart rate was 72 beats per minute. And it's interesting, 90%, 92% were on beta blockers and 30% on digoxin. And despite that, their heart rate was 72 mean. So they really didn't get it down to a heart rate of 60 like we discussed yesterday. So what happened when they used the medication? And it's interesting, the impact was substantial. In fact, the p-value in this study was 0.000004. I mean, I've never seen a p-value of that significance. And quite frankly, I was surprised because I thought we had completely done neurohormonal blockade with ACE inhibitors, beta blockers, and spironolactone. And so there was a 20% reduction in death from cardiovascular causes and 21% reduction in heart failure hospitalizations. And death from any cause, there was a 16% risk reduction. So I'm going to go to some of the key slides given the interest of time. So when you look at cardiovascular death, I want to repeat that 20% cardiovascular death, 20% heart failure hospitalization, overall mortality 16%. heart failure death, so the pump function, there was a 20% reduction, and sudden death, there was a 20% reduction. So there was 20% reduction in sudden death with an ARNI. And typically we look at beta blockers as antiarrhythmic, and that's why we, when I showed you that pie diagram from the MERIT heart failure, we said, okay, beta blockers were efficacious because they not only improved pump function, but they also prevented ventricular arrhythmias, atrial arrhythmias. But if you see, even ARNIs reduce sudden death by 20%. And if you look at the mode of death, again, when this is another figure where you see all-cause mortality, death due to cardiovascular causes, sudden death, and worsening heart failure, all p-values were very, very significant in the paradigm heart failure. One of the interesting takeaways from this study was an early mortality benefit. So if you look at all the heart failure trials, whether it was solved or any of the trials, the survival curves separated over 6 months. So I even tell my residents and fellows, if you skip a medication for a day or two, it doesn't matter. You really have to give it for 6 months to have a meaningful improvement in survival. But it's interesting. This is a slide which Scott Solomon shared with me. They found survival benefit as early as 4 weeks. And at 8 weeks, it was 0.0007 significance in the early, so there was early mortality benefit with ARNIs. So of course there were adverse events, and the 3 big adverse events were symptomatic hypotension, discontinuation of drugs was not significant, and it was very similar both in the enalapril group and in the ARNI group, and angioedema was not significant, but there was a slight, if you look at the numbers, more patients in the ARNI group had angioedema. And remember, when you look at the ARNI group, these were the people who were in this study were the ones, there was a run-in period. So they chose the squeaky clean patients. It's not the real world patients which you and me see, okay? So all these numbers, you need to keep that in context when you prescribe. So when you look at, in my earlier slide, I opened the slide with Milton Packer's comments that there's a less than 20% benefit. So if you look at what we do to save lives, ARBs and ACE inhibitors improve survival by about 20%. Beta blockers, as you know, is a big deal. In fact, I remember, we started using ACE inhibitors, we saw some survival. And then when beta blockers came somewhere around late 90s and early 2000, I remember Bill Armstrong was the director of the Echo Lab, he wrote the Echo book with Tom Ryan. He was completely and pleasantly surprised that the EF improved from 10 to 60%, especially in the non-ischemic cardiomyopathies. So there's no question the survival benefit beta blockers was between 30 to 40%. Both the EPHASIS and the EMPHASIS studies showed that mineralocorticoid receptor blockers are very efficacious too. In fact, I think not all patients have secondary hyperaldosteronism. When you give diuretics, in some people the potassium goes down and they become hypokalemic. They have more secondary hyperaldosteronism than the ones whose potassium doesn't go down. And you could argue that in a setting like here where cost is an issue, if you had to select spironolactone or eplerenone, you may want to do it in people whose potassium is lower rather than higher. And then, of course, in the African Americans who have significant hypertension and non-ischemic cardiomyopathy, the combination of nitrates and hydralazine has been shown to be efficacious. So, where does ARNI come in? So, I showed you, discussed there was 15% improvement in survival with the ACE inhibitors. What neprilysin inhibition does is adds another 15% double-digit improvement in survival. So there's a doubling of survival with ARNIs. And I must say, despite all the data, I was a late adopter. And now that I'm using these medications, it's been very gratifying to see patients tolerate the drug, and B, there's significant improvements in ejection fraction. So if you look at the cost effectiveness of this. Greg Fonerow from UCLA did this. When they looked at, they projected that, especially in systolic heart failure, at least 2 million patients would benefit from implementation of RNA therapy and would prevent nearly 28,000 deaths a year. So it does save lives. I think the big takeaway is, if your patient can afford it, don't be gun shy for using it. So I'm going to stop here. I just want to say that I'm a heart failure guy. We have these 2 books. The Atlas just came out, and I told you about my internal textbook. Given the interest of time, I'll stop here and I'll be open for questions if the panel